The traumatic transection of the thoracic aorta is a life-threatening condition which carries an out-hospital mortality of 85%. Often, the survivors of traumatic aortic transection have injuries in multiple organs such as the brain, abdominal organs, and bones. 75% of transections occur during road traffic accidents. In 60 to 90% of cases, the transection occurs in the area of the isthmus of the thoracic aorta. Other areas also affected are the ascending and distal descending thoracic aorta at the level of the diaphragm. During the accident, the combination of different forces such as stretching, shearing, and torsion on the thoracic aorta lead to the transection. Other mechanisms of thoracic injury are the water hammer and osseous pinch effects. The gold standard of diagnosis is CT angiography, which is useful for appropriate measurements, such as the diameter of the thoracic aorta proximally and distally of the site of the transection, and the distance from the left subclavian artery to the transection. The open surgical repair of aortic transection has a mortality rate above 10% and significant paraplegia rates. The endovascular technique for the treatment of aortic transection is performed under general anesthesia and includes open cut down of both common femoral arteries and of the left brachial artery and insertion of sheaths for diagnostic angiography. The appropriate orientation of the C-arm is also significant when attempting to optimize the visualization of the thoracic arch. The stent graft delivery system is introduced under fluoroscopic control, and the placement and the final result are confirmed by digital subtraction angiography. Here you can see the procedure of the placement of the stent graft step by step. At the right, you can see the final images of CT angiography where we can see the good result. There are two meta-analyses comparing the open and the endovascular repair. The mortality rate for the endovascular approach is 8%, and for the open repair is 15 to 20%. The paraplegia rate is 0% for the endovascular technique and 5 to 7% for the open repair. The critical point is the timing of the repair of a transection. If there is an aortic-related hemodynamic instability, the transection is treated first. If the hemodynamic instability is not aortic-related, the life-threatening injuries are treated first. The transection is treated within the next days when the patient is hemodynamically stable. The occlusion of the left subclavian artery occasionally may lead to paraplegia, stroke, and left upper extremity ischemia. It is preferable to revascularize this left subclavian artery when there is a long aortic coverage, a prior or concomitant infrarenal aortic replacement, a dominant left vertebral artery, and a patent left internal mammary artery. Risk factors for endograft collapse are oversizing more than 10%, a sharp aortic arch angulation, and a small aortic diameter in young patients. We can prevent it by oversizing up to 10%, overstanding the left subclavian artery, and selecting stent graft with better apposition, more radial force, and pre-curved configuration. Treatment of a collapsed endograft is ballooning, Palmaz stent placement, and proximal insertion of a new stent graft. The Gore company introduces in 2010 a new thoracic aorta graft by the name of C-TAG. Letter C derives from the first letter of the word conformability. The graft introduces significant changes which help prevent collapse in the area of the aortic arch. The new improvements are elimination of the flared scallops and covered proximal stent, which optimizes graft apposition. Increased wire diameter, which optimizes radial force with the resultant increased resistance to compression in high flow rates. Ninth apex added to stent pattern, which further distributes point load and contributes to adequate fatigue life in maximum oversizing condition. Medtronic has improved the delivery system of the Valiant stent graft, which will be named Valiant Captivia. The new delivery system offers the addition of tip capture, which enhances control of deployment, precise stent graft placement, and conformability, and possibility to treat a broad range of anatomy. Endovascular treatment of traumatic aortic transections is a safe and effective therapeutic method with low morbidity and mortality. It requires long-term follow-up, and more technical improvements of stent grafts are required. It should be the therapy of choice.